All right, today I'm going to be talking about a drug called Ocrelizumab and its use in multiple sclerosis. So a review of what multiple sclerosis is. It is a disease that's considered to be immune modulated, and it's where the myelin sheaths, which are the fatty insulating layers on neurons, are destroyed, and the scarring is called sclerosis, and then nerves can end up becoming permanently damaged. So the myelin is important for both protecting the neurons as well as conducting signals down them. So there's a lot that we don't know about MS, and you're going to see that as we go through the presentation. So we have drugs to treat it, but there's a lot of unknown factors. And risk factors associated with the development of MS have been proposed. I've highlighted a couple here on this slide, and although we don't know the exact mechanism, we know that there is an increased risk with these risk factors, and these people have, or I guess they have a higher risk of developing MS. So women are about 2 times as likely as men to develop MS. People who are Caucasian are more likely to have MS. Family history plays a role, so people who have a family history of MS are at an increased risk. The Epstein-Barr virus, which is the virus associated with mono, has been shown to have some association with MS. It's more that people who have MS actually have increased antibody production to the Epstein-Barr virus, so we're not really sure of what that mechanism means. Smokers are more likely to have MS, and then people who have other autoimmune disorders like type 1 diabetes and inflammatory bowel disease are more likely to develop MS. Most people present with symptoms between the ages of 20 and 40. And over on the right-hand side, you can see a diagram that goes through the common presenting symptoms for MS. And as you can tell, they're pretty nonspecific, so they could be associated with a lot of different diseases. So sometimes the diagnosis time to actually getting an MS diagnosis can be quite long. The most common symptom that people have is numbness and tingling, and that's because the neurons are being damaged and causing those sensations. So there have been 4 classifications of MS, and the important thing to know is that individuals have very different courses of the disease. So even if 2 people have, for example, relapsing remitting MS, the way that their disease progresses can be drastically different. So I'm just going to review the 4 categories that we have. The first is the clinically isolated syndrome. So this is an episode of symptoms that's lasting at least 24 hours. Some people who have a clinically isolated syndrome will go on to be diagnosed with another kind of MS. And some people actually never have MS-like symptoms again, which is why we have our own categorization for it. Relapsing remitting MS is by far the most common diagnosis that people receive. It's about 85% of people who present. And over on the right-hand side, I have some different diagrams that show you sort of what the progression of these different disease categories can be like. So with relapsing remitting, people will have a flare-up of symptoms, and then over time they actually can lose those symptoms. Sometimes they go back to baseline. Unfortunately, MS is a progressive degenerative disease, so even with relapsing remitting, as you can see, over time they are gaining disability due to their symptoms. Now, relapsing remitting MS can eventually go on to become secondary progressive MS. So this is despite the fact that they started with these relapsing and remitting periods, they get to a point where disease progression is fairly steady. And primary progressive MS, which is going to be an important one for us talking about ocrelizumab, is that from onset, patients will accumulate symptoms and disability without any of those remitting periods where they go back to baseline. So this is a diagram that I pulled from the DiPiro chapter. It's an algorithm for the treatment of MS. It's pretty complex, so I just want to highlight a few areas. I want to look at, over on the right-hand side, we've got relapsing remitting MS and primary progressive MS. So relapsing remitting, as you can see, it connects to all these boxes down here. And really what this is telling us is just that there are a lot of different treatment options for relapsing remitting MS. I do want to point out that the treatments we have do not cure the disease. They are actually just to slow the progression of the disease over time. The boxes I've highlighted in red show where ocrelizumab has been added to the algorithm. And another thing to point out is that this is not showing first line, second line, third line like we look at in a lot of disease states. This is actually looking at different patient characteristics, like being the John Cunningham virus positive or negative. And based on those patient characteristics, what are some options that we should consider in their treatment? Now, the yellow box in the upper right-hand corner shows the treatment algorithm for primary progressive MS. As you can see, it's fairly small, so it says there's no FDA-approved prescription products, which actually that hasn't been fully updated because ocrelizumab is a new drug. So we'll talk about that a little bit later. But basically it says that if you are diagnosed with primary progressive MS, your options are an experimental treatment, so being enrolled in some sort of drug trial, or using rituximab if you meet certain characteristics. So our review here, relapsing remitting MS and secondary progressive MS have many treatment options available. We use disease-modifying therapy for long-term treatment. By far the most common is interferon beta, which is a subcutaneous injection that a person will give themselves 3 times a week. We also have other medications like natalizumab and rituximab. Now, I mentioned rituximab on the last slide. It is important to note that it is not FDA approved for use in MS. Acute flare-ups are treated with courses of corticosteroids and plasmapheresis. And as you saw on the last slide, primary progressive MS has limited treatment options. So now we're going to look at really where ocrelizumab fits into this. So ocrelizumab was approved in March of 2017, so about a year ago. It's a humanized antibody that targets and depletes CD20 positive B cells. This is the same mechanism of action as rituximab, the difference being that ocrelizumab is a humanized antibody and rituximab is a chimeric antibody. So the risk of a person developing antibodies to rituximab and rendering it ineffective over time is much higher. Like other immune-suppressing agents, ocrelizumab is not to be used in an active hepatitis B infection. And ocrelizumab is approved for treatment of relapsing remitting MS and primary progressive MS. So that chart back a couple slides that said there were no prescription products approved is actually waiting to be updated to add ocrelizumab to it. So ocrelizumab is dosed as a 600 milligram IV infusion given every 6 months. The first dose is split into 2 300 milligram doses given 2 weeks apart. And then every dose after this will be given as a single IV infusion of 600 milligrams. It costs about $65,000 for 1 year of treatment. And per the National MS Society, this is actually 20% below the average price of other treatment options. So a lot of the drugs that we've mentioned up until this point cost at least $60,000, if not more. Some of the noted adverse effects are a high rate of infusion site reactions, and this actually requires pre-medication. The package insert for ocrelizumab recommends giving an antihistamine and corticosteroid before running the IV infusion of ocrelizumab. Ocrelizumab is an immune-suppressing agent because it's depleting B cells, and so we also see upper respiratory tract infections and some other minor infections. There is also a warning for ocrelizumab that there is an increased risk of malignancy, particularly breast cancer, in patients receiving this drug. So now I'm going to take you through some of the studies that brought ocrelizumab to market. The first 2 are OPERA-1 and OPERA-2. These were 2 phase 3 trials. They lasted 96 weeks. And although they were conducted separately, they were published in the New England Journal of Medicine together because there was some pooled analysis that happened in the statistical section because of the similarity between the patients, and this was planned before the trials were conducted. So each trial had about 800 patients who were diagnosed with relapsing remitting MS and had a history of relapses. Anyone with primary progressive MS was excluded. Also, patients who had been previously treated with B-cell therapy, as well as patients who had a long duration of MS who had not developed significant disability over that time. So ocrelizumab, 600 milligrams IV every 24 weeks, was compared to interferon beta 1A, 44 micrograms sub-Q 3 times a week. And this is a standard therapy that's used in MS. The endpoints that the study looked at were annualized relapse rate, safety endpoints, other measures of function in relapse, and also MRI data. The results found that comparing ocrelizumab to interferon beta, there was about a 46% decrease in relapse rate with ocrelizumab. They also looked at disability progression at 24 weeks. 6.9% of the ocrelizumab-treated patients had disease progression, and 10.5% of the interferon group did. Now, unfortunately, the multiple sclerosis functional composite score was not able to show statistical significance. So this is a functional measure that looks at walking speed, upper limb movements, and cognition in multiple sclerosis patients. OPERA-1 did show results that favored ocrelizumab, but OPERA-2 did not have statistically significant difference between the two arms. And this is looking at some MRI data from OPERA-1 and 2, and it looks very dramatically different. So this is measuring the number of lesions in the patient's brain. And as you can see, ocrelizumab has significantly fewer lesions at 96 weeks than the interferon group. Unfortunately, the problem is that we don't know that the number of lesions actually correlates to disease progression. So although it looks impressive, we don't know that this means that the drug is that much better than interferon at preventing progression of MS. And these are some safety endpoints that were noted from the trials. So about 35% of the ocrelizumab participants had infusion site reactions, and this is why it's recommended to pre-medicate patients. Serious infections occurred in 1.3% of the ocrelizumab arm and 2.9% of the interferon arm. And there were no opportunistic infections in either group. Now, if you remember, the package insert also contains a warning about malignancies. So neoplasms were found in 0.5% of the ocrelizumab group and 0.2% of the interferon group. And the special warning for breast cancer comes from these trials. So ocrelizumab had 2 invasive ductal breast carcinomas develop, and then in the open label extension after the trial saw actually 2 more breast cancers develop. Interferon did not have any breast cancer development and only 2 cancers overall. The third trial that brought this drug to market was Oratorio. So this was also a phase 3 trial. It lasted 120 weeks, and it looked at 732 patients who were diagnosed with primary progressive MS. It compared ocrelizumab to placebo. The endpoints that were looked at were the percent of patients with disability progression confirmed at 12 weeks, and then at 24 weeks. They also looked at functional measures like the 25-foot walk results and safety endpoints, as well as some MRI data. So Oratorio saw at 12 weeks that 32.9% of the ocrelizumab patients had disability progression, and 39.3% of the placebo patients had disease progression. And even just looking back at the OPERA studies and the progression rates that they saw, 30% was much higher than what we saw in the OPERA studies because primary progressive, you're not having those relapses and remittance episodes. You're just having straight progression of the disease over time. At 24 weeks, we saw 26.9% versus 35.7% progression. Important adverse effects that were noted in this study were infusion reactions, upper respiratory infections, and oral herpes infections that were all more common with the ocrelizumab arm. Also, neoplasms were found in 2.3% of the ocrelizumab patients versus 0.8% of the placebo patients. And over on the right here, I'm also showing some MRI data from the Oratorio study. So they looked at total volume of the brain lesions when they conducted an MRI. And as you can see, the ocrelizumab group actually had a reduction in lesion volume. And when looking at total brain volume, both ocrelizumab and placebo patients had a decrease in brain volume, but it was a statistically larger decrease in the placebo group. So in conclusion, ocrelizumab fits into therapy as an additional disease-modifying drug approved for the treatment of relapsing remitting MS, and it is the only FDA-approved medication for the treatment of primary progressive MS. We saw through the OPERA and ORATORIO studies that ocrelizumab has benefit in treatment over interferon and placebo. It's important to remember that ocrelizumab does have a high rate of infusion site reactions and requires pre-medication before giving the IV infusion. There is also an increased warning for malignancies, in particular breast cancer, in patients who will be treated with ocrelizumab. Here are my references, and thank you for listening.